Good afternoon, everybody. Uh, Thank you, chairpersons and delegates and senior faculty. It's a pleasure to be here for this Hematology for All, conducted by the Indian Society of Hematology and Blood Transfusion with IMA. It's a pleasure to see the cooperation we got from local organizations, which we are really very happy to see the cooperation would help in future also as well. And I am the first giving the talk on the approach to a child with bleeding disorder. The bleeding disorder, the diagnosis there are many causes of bleeding disorders. But just to start with a negative information that many, even including some medical colleges, do not do the minimum range of coagulation tests to reach a correct diagnosis of the exact cause of the bleeding. Because even physicians are not aware of the spectrum of investigation required to reach a diagnosis, because it is just every patient would present with a bleeding, though the causes are very varied, whether it is a functional disorder like platelet function, or inhibitor, or a factor deficiency, and everything is not, can be very rare ones, like the only we know the hemophilia, factor 8 or 9, though are the commonest, but there are the other, many other rare factor deficiencies which can cause also the bleeding, severe bleeding problem as well. So many times even the obsolete tests like bleeding time by the finger prick or the clotting time by a capillary tube method, they are very obsolete and no more in the books also. So that's how everybody should be aware of the spectrum of tests as well as the diagnosis which are required. And when you talk of children, actually it's from 0 to the 18, even sometimes pediatrician to take as 21 as the children. So basically we have the full spectrum of 0 to 21 can present with, so that whole spectrum we should discuss this. The bleeding problem is variable. It can be very small bleeding like maybe some petechiae or maybe the occasional ecchymotic patches somewhere in the skin, maybe the soft areas like the thigh or the abdomen. Or that can be, again, roughly the coagulation factor deficiencies. It correlates with the factor levels. Like if it is less than 1%, likely to be severe. It's something like 1 to 5% to be moderate. Roughly more than 5% to something like 40 and 50% is considered as a mild bleeders. These mild bleeding disorders, which we will consider called as MBD, mild bleeding disorder, they mostly do not cause any active intervention, and in a static state do not need to intervention, but they do cause a psychological stress, because finally blood, obviously everybody is afraid to see the bleeding from anywhere, it is small or large. And of course, they are always at high risk of bleeding at surgery. This is the study, just to give one spectrum of the bleeding disorders. The preoperative history and coagulation screening in children undergoing tonsillectomy, a common surgery earlier, about 1,600 patients. They were, when investigated, the 13 of them had persistent lab abnormalities and were found to have hemophilia A or von Willebrand disease or have non-lupus inhibitors, so lupus inhibitor or a persistent prolonged hepatitis. So that means the children can have also all these conditions, whether inhibitors as well as the coagulation defect deficiency disorders. And usually, of course, all these patients were deferred for surgery. So there is no clinician, no surgeon will take up with bleeding abnormalities. And now another thing is also, which is a standard practice, is the questionnaire used before surgery. That's of course because in absence of any other alternative, it is a very effective utility, whether it be the international anesthesiology or different surgical associations. The recommendations are by the questionnaire to see whether there is history of any past history of bleeding or family history of bleeding. But exactly this study shows that the questionnaire is not really that helpful. But of course, any patient with a positive history of excess bleeding, himself or herself or in the family, they need to be investigated further to find the exact cause. Degree of bleeding, I said, is variable. Sometimes are very severe, like it presents from birth, or can be very mild throughout life, may not present, or may be present only in adulthood. So it's a very long latent period. So with respect to that, the variability is very high. And this topic will not discuss the secondary causes of bleeding disorders, like which are very obvious, like septicemia, or a severe liver disease, or DIC, with malignancy. All that will not discuss in this talk. So the remains is the isolated bleeding disorders. It can be both hereditary as well as acquired. Hereditary, usually they are single factor deficiencies or single cause will be there, like usually mucocutaneous. It can be usually platelet function disorders or commonly von Willebrand disease or hematomas. Usually it is the coagulation factor deficiency or congenital thrombocytopenia. Acquired causes of bleeding disorder, commonest is the thrombocytopenia, which is obviously obvious by just doing a CBC. One can demonstrate there is a low platelet count, and if a significant low platelet count, we will have a significant bleeding disorder. The coagulation factor inhibitors like collagen, as you said in one study, that can be again cause bleeding disorder, or a liver deficiencies. Usually they are multifactorial, not a single factor defect. Bleeding in newborn. So we are talking of very early young child, of a newborn within 28 days. The commonest cause the acquired causes are more common, and in that way the top one is the vitamin K deficiency called VKDB, vitamin K deficiency bleeding disorder. Others are the acquired causes, so I will not go over it. And another thing is that the neonates, though we know that all the factors compared to the adults, the levels are low, whether it is factor 5, 7, 9, whatever you take, so 10, all that are really low level, but it doesn't cause increased bleeding in normal child, because it is a balanced out because of there is the natural anticoagulant like protein C and protein Ls are also reduced. So both are reduced, so they counterbalance to each other. And also a von Willebrand factor is the exception. It is higher in level of the neonates. So vitamin K deficiency, the bleeding disorder newborn, the acquired and the commonest one. Usually it is more common in the premature infants or the mothers on certain medications. They are more common. And bleeding usually occurs in the first week of birth and can be from anywhere, including nose, umbilical, hematoma, ecchymosis, GI, everywhere. And of course nowadays a standard practice to counter it by the injection of intramuscular single dose vitamin K injection of 0.5 milligram in infant, less than 1500 gram, or 1 milligram per more than normal weight, more than 1500 grams. So that's a routine practice. Of course, it is not that every case of vitamin K deficiency occur in before only within 1 week. Sometimes late, after months of can be there, which again can be also vitamin K deficiency. One should be aware of that. That's called the late onset vitamin K bleeding deficiency bleeding disorder. So that again, either if there is a liver disease or only breastfed, the solid food are introduced, those cases also one can have the bleeding problem. Coming to the hemophilia, the occurring in the neonatal period called the neonatal hemophilia. As usual, it is the factor 8 and 9 deficiency. Again, the bleeding because of the young child, it can have the specific areas like the cephalohematoma or the pulmonary hemorrhage, as well as the venipuncture site, the intraventricular hemorrhage. These are more serious bleeding are associated with neonatal hemophilia. They are relatively higher frequency in preterm infants, and of course in term infants, if there is infection or there is hypoxia, ischemia, so there could be again more higher frequency of bleeding occurs. In this neonatal period, neonates, the other factor deficiencies should not be forgotten, like the factor 7, factor 5, factor 10, factor 11, vulnerable disease. One should not forget, they are there. Once you exclude the common one like factor 8 and 9, all the others one should also keep in mind. Again, in young age, another important site bleeding is the umbilical storm bleeding. Normally, the umbilical storm falls off in 7 to 14 days. So only a spotty bleeding normally do occur. But any excess bleeding, and if it is looking, the stump is looking healthy, so it is need to be investigated. The common causes of the umbilical storm bleeding are the fibrinogen abnormality, the factor 13 deficiency, factor 2 deficiency, and in some cases of factor 10 deficiency, rare ones can be there. But more common are the 13 and fibrinogen and factor 2 deficiency. The test interpretation of a coagulation test in the newborn, again depending upon whether they are born preterm or full term, the interpretation of tests, you cannot take the range of the normal range of spectral tests of prothrombin time or activated partial thromboplastin time or the fibrinogen level. They will be a little different, so that also one should keep in mind in interpreting the tests. The history is important in suggesting hemostatic defect like menorrhagia, since menarche in 5 to 10% cases are due to vulnerable disease. The hematoma with trivial trauma is more likely to be a hemostatic defect and need investigation. Or there is unusual bleeding from or for longer period from any cords, or bleeding at circumcision or that vaccination site, or hematoma at intramuscular site. So these are again are important indicator that could that a history of hemostasis need to be investigated. The other coagulation factor abnormalities, hemostatic, they are related to different site bleeding. Like hemarthrosis is a very common and serious one. We know it is the hemophilia like factor 8 and 9, but rarely factor 5, fibrinogen, factor 13, even platelet disorders, Glanzmann's are the most serious functional platelet disorder, Glanzmann thrombocythemia, they can present with hemarthrosis. Epistaxis and easy bruising, though we know that it is more common with the platelet function disorder or thrombocytopenia. But again, factor deficiencies like factor 5, 7, 10, even fibrinogen can also do present with this. So one should be, and again, menorrhagia is not just the vulnerable disease, but again, some factor deficiencies like 2, 5, 7, 10, fibrinogen, 13 can also do present. Intracerebral bleeding are more serious one, but they can be there in factor 13 deficiency, pivinogen deficiency, factor 5 deficiency, and severe thrombocytopenia. Again, about 1% cases can be associated with this serious bleeding. So at whom to investigate the recommendation, I have taken only one, the International Society of Thrombosis and Hemostasis. The bleeding episode where the therapy is required, you need an intervention, so that need to be investigated. Or a single bleeding site, if it is occurring more than 3 times at one place, need to be investigated, provided your local cause is excluded, or more than 2 bleeding sites, again likely that it could be a more hemostatic abnormality. So diagnostic approach, there are, because as I said that there are varied causes of hemostatic defects, so multiple tests are to be done. And this test includes one you call the screening test, like PT, APTT, the thrombin time, bleeding time, and platelet count, as well as the clot solubility test. So these 5-6 tests are under the screening test, and some other tests like the mixing test, for the screening test for the inhibitors, coagulator factor assay, platelet aggregation study, some flow cytometric tests, or tests of this full spectrum of tests for the vulnerable disease. So these are again are important. Of course, when the bleedings are too obvious, like hemoarthrosis in a boy, and presenting at about 10-12 years, so it's more likely of the hemophilia. Straight away one can do a factor 7, factor 8, or factor 9 assay, can reach a diagnosis. But all rest of these tests, particularly mild and moderate, most likely that you have to go through the screening tests and further mixing tests and the factor assays to reach a clear diagnosis. And as I said that the obsolete tests should be, because that do not give any neither sensitive nor they are appropriate tests, and only specific tests should be done. And out of the bleeding time, clotting time is no more even the books also not right, but even bleeding time only in standardized methods, like the template method are acceptable because they are very sensitive. They are important for diagnosis of platelet function disorders, but though there is a low sensitivity. But bleeding time is now replaced with the platelet function analyzers, 100 or 200. They are considered more sensitive, and the alternative methods as well. The screening test, one can do when a semi-automated coagulometer is adequate, but only when all the 3 tests like PT, APTT, and TT are normal, then what one should do? Then factor 13 screening test, the clot solubility test must be done, because that's one test where all the 3 tests, screening tests can be normal. And of course, when the PT, APTT, and TT both are all normal, it's more likely that it is a functional the platelet disorder. So a bleeding time or the PFA analyzer and the tests are required. The PT, APTT, these tests are highly specific tests, but there is some limitation, like very mild deficiencies, like more than 30%. Even if we consider normal is more than 50 to 60% the normal factor levels in adults. So less than even 30%, or more than 30%, 30 to 50, that range, though there is a deficiency which can cause bleeding during surgery, but it will not be detected by the test. Maybe a factor assay would be helpful. And for the PT, a thromboplastin reagent with lower ISI value closer to 1 is always a recommended test. Same thing like activated partial thromboplastin time. All the reagents of different lots are not equally sensitive to unfractionated heparin. The common tests, most of the unfractionated patients on unfractionated heparin are the doses are calculated along as per the APT test levels and the ratio. So that's again Lupus article is another test where hepatitis is prolonged. So there again, variable sensitivity to the reagent. So every reagent, the laboratory has changed the lot. Then it has to be validated with the samples from patients on non-fractured heparin and also the patients on known lupus anticoagulant positive samples. Bleeding time, as I said, that it is not only related to function disorders, also from vulnerable disease are important. But the sensitivity is about around 50%, and no linear relation with the platelet count, though bleeding time also prolonged in severe to moderate thrombocytopenia. PFA 100 to 200, this is more like point of care equipment, and because you are doing on a whole blood, so the abnormality is again not that 100%. Vulnerable disease is a spectrum, as you will know, that it is very mild to severe. So that's why it is positive only moderate to severe abnormalities. So it's 60% cases of vulnerable disease. And many type 1 vulnerable disease where the levels can be quite normal, closer to normal, and very low deficiency level. So and even it will be normal. Again, false positive also reported in about 16% normal control, so one should be aware of the limitations. And of course, the abnormalities of PFA 100 or 200, they are not, they are only screening tests, they are not the confirmatory tests. The confirmatory tests for the platelet abnormalities are the platelet aggregation study. So one has to be confirmed with platelet aggregation to confirm the abnormalities. This coagulation test, very important, is the sample collection, the laboratory test procedure. So one should always, it has to be pre-flow blood with a higher gauge needle should be used. And again, the tubes need to be filled up to the mark. What you say up to the mark means with 10% up or down, not really very high. So I think that the important again samples are clotting and hemolysis. They are again very important. So these are because it will affect the coagulation test. So that's how one should be very careful about the sample. They are up to the mark or not. Again, the duration. The test should be done within the period 3 to 4 hours, and that also again are important. And accuracy and precision again also important because internal quality control, the LJ chart, so all that, and also participation, equas, also one should be always to be done. Okay, let's come to the interpretation of these screening tests. On that basis, one can see if all the tests are abnormal, it is more likely a acquired deficiency like DIC, liver disease, or vitamin K deficiency, or a congenital fibrinogen deficiency. That's one where it will be, all tests will be abnormal. If it is only PT abnormal, it is more likely factor 7 deficiency. And if it is only a PTT abnormality, it is called the hemophilia factor 8, 9, or 11 deficiency. Same also in vulnerable disease like type 1, 3, 2N, or the lupus anticoagulant, factor 8 inhibitor. They are only the single test, the APTT is the abnormal. If the PT and APTT, that the common part, the PTA, only PT and APTT are prolonged, so there is more likely it is the factor 2, factor 5, and factor 10 deficiency, the common pathway defect. And if all three are normal, as we said earlier, that is factor deficiency and also vulnerable disease or the platelet abnormality should be considered. I can skip this slide that you know. The second level of test, as we said, that again must be available because once you know the tests are, if they are abnormal, then one should do the correction study or mixing studies, the screening tests for inhibitor, and factor assays. There's like common factor assays, at least 3 should be available in each lab, factor 8, 9, and fibrinogen assay. Rest we can leave it to the referral laboratories. The mixing studies, they are just because they are done with normal serum or the adsorbed plasma. So I will not, there are some where it will be not useful, as I say, mild factor test abnormalities. Obviously, you cannot interpret the test. So we cannot do that. Or the factor deficiency with factor inhibitor, again, the mixing study will be not useful. The mixing studies will be useful if this with normal serum and normal adsorb plasma. You can interpret a specific test based on which test you are mixed with for the PT test abnormality or it is APT test abnormality. So that's it is an important test. Screen test for inhibitor, whether it is immediately after mixing with normal, this is done with normal pooled plasma, whereas the correction studies, mixing studies are done with the adsorb plasma and the serum. So again, if the 50% correction occurs, it is a factor deficiency. If it is occurring after 2 hours, so it is a late onset, it is more likely a inhibitor or a lupus antibody is more likely. At least 2 minutes I'll take. The referral lab tests are the other tests which you can leave it to a referral laboratory, like all the vulnerant disease diagnosis, the platelet aggregation studies, the other factor assays other than factor 5, 8, and 9, the inhibitor assay, the flow cytometric diagnosis of Bernard-Soulier disease or glandular thrombocytopenia. So all that we can leave it to the referral lab tests. So for the vulnerant disease, there is spectrum of tests required once we have done the APTT, and factor VIII-C can be again reduced in some subtypes of vulnerant disease. The ristocin aggregation, the RIPA, the ristocin-induced platelet aggregation at low dose, the vulnerant factor, ristocin cofactor, this ratio, AG ratio, the antigen assay, the cofactor assay. So molecular factor, molecular weight study. So a large number of studies. So I don't expect routine laboratories to do these tests. The platelet function disorder, again, as a specialized laboratory, the common ones are Bernard-Soulier disease. The diagnosis can be made by flow cytometry. Same thing, Glasmania can be done by the GP2B3A defect, by the glandular thrombocytopenia by flow cytometry. So all that one can diagnose it. So I summarize. The hemostatic defects are very varied etiology, therefore multiple tests are needed to reach a clear diagnosis. The quality control should be an integral part of every laboratory, including EQUAS, IQC, calibration, everything. The standard screening tests must be available in every hospital. Most sophisticated tests can be done in referral centers. Thank you.